Okay, so you guys come on up so you can see a little bit. Just stay sort of back there somewhat. And we're talking about intubation. Intubation, endotracheal intubation, okay, is what we consider definitive airway control. Okay, so if I'm going to control my patient's airway for some reason, the definitive means that it's the absolute airway control. So when you have someone intubated, you're in control of their airway. And it's definitive because of the endotracheal tube itself. It blocks everything off from going down. So fluids, vomitus, blood, secretions, whatever, it's going to block that off, keep it, the absolute majority of it, keep from going down the trachea. We don't want fluids going down the trachea because that leads to aspiration pneumonia, which is going to lead to death a lot of times. So we don't want to do that. And it's as simple as this cuff I'm going to show you in just a few minutes that blocks off the airway for us. So that's a very important aspect of the endotracheal tube, which some of the rescue airways that we'll go into doesn't have. So the reason that we do an intubation, one, they're dead, they're in cardiac arrest. We're going to intubate them. We want to breathe for them, right? The other one is respiratory arrest. They're not breathing, so we're going to intubate them to maintain complete control of their airway or definitive control of their airway. Others is pending respiratory failure. So this patient's about to stop breathing. So we're going to intubate them and control their airway. Maybe they're not breathing enough. Maybe they're breathing too fast. So you have two different things that we're going to control their airway on. They're not getting enough tidal volume, so we want to intubate. This, if the patient is breathing, most times in either an EMS setting or a hospital setting, they do what's called a rapid sequence intubation or an RSI. And then they give them medications. We're not going to go into the medications now, but they give them two medications. They first sedate the patient, because if they paralyze them before they sedate, then the patient knows that they're not breathing. And it's horrible. I've had patients tell me that they were intubated without the proper sedation, and they knew they weren't breathing. They knew they couldn't breathe. So that would be horrifying to know that. So we sedate, and we sedate with different things. And you don't really need to know the medications at this point, but other medications, Versed is a benzodiazepine, and it's great for intubation. Hold a moment, hang on. I was just talking about it this morning. What's that medication I was just telling you about? Suction, etomidate. Yeah, etomidate is another good medication that we use. They have ketamine now, called a vitamin K. It's pretty powerful sedation. You can sedate them with fentanyl and Versed. I mean, there's just a combination of things that we sedate now. But then, and a lot of times when you sedate the patient, you can go ahead and intubate them because they're flaccid. They're not resisting the tube. The reason that we want to go ahead and maybe paralyze the patient is that they're breathing and we can't get them intubated in between breaths, or they have a gag reflex. So we want to go ahead and do this. Once we sedate, then what I do is I go in and I look to make sure that I can see the structures and I can get the patient intubated. And a lot of times I'll go ahead and pass the tube and intubate the patient prior to giving a paralytic. There's a couple of different types of paralytics that they give. One is and they're all sort of neuromuscular blockers, but there's succinylcholine, and then there's which is we just talked about this. Such as a depolarizing neuromuscular blocker, which means that the patient's going to have fasciculations, or they're going to look like they have little seizures because it depolarizes the synapses. Essentially, that's not 100%, but it blocks the neurological input into the muscles. It paralyzes every muscle, including the diaphragm. Doesn't paralyze the heart, obviously, that would be fatal, but it paralyzes the diaphragm, so the patient stops breathing. And then there's non-depolarizing neuromuscular blockers, which doesn't cause that effect. There's problems with both, okay? This is not that type of class, so we won't really go into it. So we're doing RSI, we're going to do the intubation. There's problems with intubations. Mainly problems is unrecognized esophageal intubations, because there's only two places that these tubes don't go. It's either don't go where it's supposed to, into the trachea, or it's don't go into the esophagus. Now, if it goes into the esophagus, we should know it fairly quick with the procedures that we have to confirm the tube, but we'll know it even quicker because when this tube goes into the esophagus, it causes a drastic change in pressure. So the outside pressure is a lot less than the inside pressure. So whatever's in the stomach is going to feed back up through this tube. So you don't get stomach contents in this tube if they have anything in the stomach. So when you see a green bean coming back up through the tube, you know that you're in the wrong place. You see breakfast in there, it's like, uh-oh, that's an egg, I'm in the wrong place. But we don't confirm the tubes, so that's not a huge problem. So let's look at the equipment right quick. This is an invasive procedure, so I wouldn't be holding the tube like this. Right? I keep this in the package to keep it as clean as possible because this is going into the trachea. Even with clean gloves, I don't want to hold this tube because it's going into the trachea. So we have the endotracheal tubes. There's different sizes for different people. Essentially, the size of the endotracheal tube is the diameter of your pinky. So I'm like a 7. Okay, so this is a 6 that I have. That's too small. You want to put the proper endotracheal tube in the patient because they're breathing off of this. This is how you get air in and out. So if you have a small tube, you're going to have a small airway, correct? So you don't want that. You want the proper size tube in the patient. They have them from real small straw-looking ones for pediatrics all the way up to garden hose-looking things for King Kong. I mean, so they have large tubes. So you need to determine the size of the tube. And a quick reference is that's the diameter of the pinky. And of course, there's charts and everything else, right, to go along with that. The common is like a 7 to 7.5 for a male, 6.5 to 7 for a female. Then you get into pediatrics and different ones like this. What we do is we look, when we do the intubation, finish the equipment. You're going to need a bag valve mask. You're going to need suction. This is a handheld suction, and this is quite good. It's a pump suction. And we talked about this before. So this works just like your other suction, except it's manual, right? You don't need a manual. You can use a electric powered one, but I just wanted to bring this out and show you the manual suction, and it works great. Large bore. I mean, this is a really good manual suction device, and you can work on your grip at the same time. All right. So you need suction. You need your properly sized endotracheal tube with a stylet. The stylet is just a wire, almost like a hanger, and it sits in there and it gives form to the endotracheal tube because we want it curved up like this, so it glides in to the airway. So I've intubated without a stylet before, and it's a little bit harder because the tip bends. So it just depends. Then you're going to need a 10 cc syringe, and then something to secure the tube with. If you're doing a intubation, also you probably want in your arsenal somewhere a rescue tube in case you can't get the intubation, and we'll talk about those at the last. We have an LMA and a King Airway here. The King is probably the more modern one. And then the other, you have a Lorenzo Scope. Lorenzo meaning that you're going to look at the larynx, you're going to look at the vocal cords, and then it has a light on. So as you go in there, now this is really old school, the metal Lorenzo Scope. Now they have what's called a glidoscope, and they're really cool. They're shaped like this, depending on the different blade. But on top here, they have a high definition camera. And so when you go in to do the intubation, you don't have to struggle to look like I'm going to have to with here. I'm just looking at the camera, then I'm going to pass the tube. And I can leave this in, I can leave that blade in and make sure that the tube continues to stay in the proper place. I'm looking at it with high definition. So like this is real old school. Almost everybody uses a glidoscope of some sort. I think glidoscope is actually a brand name, but they use one with a camera on here so they can see where the tube is going. And that's the important part, because when we look at the endotracheal tube, we want this passing through the vocal cords. So the black line on the endotracheal tube is a reference. So you pass this through the vocal cords until that black line disappears. Once it disappears, you stop, because another problem with it is going too deep with the endotracheal tube. And the main bronchus, the right and left main stem bronchus, one is shorter than the other, and this takes the path the least resistance. So you can go down where you're down into the right main stem bronchus or the left main stem bronchus. It just depends on which way it goes, okay? And then one lung is not expanding the way that it's supposed to. But as we look through here, you can't see it, but I'm going to look at the anatomy. So I know that the vocal cords are right underneath the epiglottis. So I'm going to find the epiglottis with, and then I'm going to pass my tube through there. And I'm going to like really stick this through there, okay? That it doesn't go there. That's way too far out. But I want to show you what happens when I inflate that cuff. That cuff sits like that up against the vocal cords. And then that way, if vomitus or fluids or anything gets down in there, it's not going to get down into the trachea. So this sits right on the sort of the inferior part of the vocal cord, just right behind the vocal cords. It's this where this sits, and it protects the airway, like so. All right. So when we get ready, one thing that I do is want to test while this is still in the package. I want to blow that up. Make sure that cuff is inflated, and then this balloon out here on the outside, of course, I'm going to take the syringe off because it'll just backfeed into the syringe because the pressure differences. And then as long as this is inflated, this cuff is inflated. So this stays outside the patient, so I can continue to monitor that to make sure that that cuff's inflated. The other thing that you're going to need is some type of Untitled CO2 detector. This is called a stack cap. And what it does, it's just litmus paper. And I'll put this on there because you're hearing them. They say, let's get a color change. Make sure we have color change. And so we'll put this, as soon as the patient is intubated, we'll put this on the top of the endotracheal tube and breathe a couple breaths in. And then it'll go from yellow to purple for a few breaths. And then I have color change because it's picking up the presence of carbon dioxide. Now this is temporary, it's litmus paper, a few breaths and throw it away. So we want to use the Untitled CO2 on a monitor. We want to have Untitled CO2 so we can see a waveform, so we can see the presence of carbon dioxide. Because if we go into the esophagus, then there's no carbon dioxide, and there's no color change, or there's no waveform. So you have an esophageal intubation is a problem, unrecognized esophageal intubation. a brainstem bronchus intubation where you had the tube too deep. Okay. And then you get into other problems where you could actually destroy the soft tissue. You could break the teeth. I'll show you that in a second. Okay. You cut a lip. I've cut lips before. It's not that big a deal. Patient's not breathing. Cut lip is minor, but you don't want to really to do that. Okay, and the last thing as far as equipment, you have the Lorenzo Scope. You have my favorite, it's the curved blade with the Macintosh blade, and there's different sizes for different people. Okay, this happens to be a 3, so it's the common one. The curved blade, I use it because it requires less forearm strength. Okay, and the curved blade, how it works is it goes into the vallecula. That's the space behind the epiglottis and the tongue, at the base of the tongue. And so it indirectly, see, it's like this, it indirectly lifts the epiglottis because it's in that vallecula. And so it indirectly lifts the epiglottis. The other blade that you have, both with this and a glidoscope, if you have a straight blade or a Miller blade, now the Miller blade directly lifts the epiglottis. So you go down there and you find the epiglottis, and the Miller blade directly lifts the epiglottis. Now there's a distinct purpose for the Miller on fatties, people with no neck. Most of the time, those patients have their vocal cords are anterior. They're real anterior, so they're up here. Okay, so they're hard to intubate. Those football players don't have any. They don't have a neck. They're hard intubations. The obese patient, they're hard intubations. So I would use a Miller on that because of the way that the anatomy is. The Miller blade is really good for anterior airways and also pediatrics. I wouldn't use a Macintosh or a curved blade for pediatric. I'd use a Miller blade because most pediatrics are anterior. They grow out of it. Okay, so they do that. So I'm going to intubate here, Fred, with the Macintosh. So I'll get everything ready, okay, and do the intubation here. I'm going to pre-oxygenate with the mask, okay. Make sure to hyperventilate them. This shouldn't take more than just a few seconds because now the patient's not breathing. Whether they're in respiratory rest or I stop the breathing process, they're not breathing, right? Let's see. Before we do that, let me talk about the rescue airways. That way I can leave them intubated. There's a couple of rescue airways. This is called the LMA, Laryngeal Mask Airway. Okay, and this is for if I can't get the patient intubated for some reason. Maybe I have them paralyzed now. I can't get them intubated. So the LMA, and they use this a lot for like day surgeries and stuff. Instead of doing an intubation, they put an LMA in. In this, I just shove this in there, and it sits over the airway like that. And then I inflate this cuff, this part with 30 cc's of air, and it sort of sits back there over the epiglottis. It's an okay airway, but one of the flaw designs on this or whatever is that it doesn't protect against secretions. So if the patient vomits or they have a lot of secretions or blood, not a good airway, because this is not definitive control by any means. So it just sort of sits in there, but you just sort of, if I was to put this in there, I'd just like shove it in, get it and then put 30 cc's of air in the cup. And there's different sizes for different people. Okay. There's another rescue airway called the King Airway, and it's just this is really a BLS. I think they're going more towards basic life support with this. And again, this is an actually very good airway. You just get head tilt, chin lift, and again, just shove it down in there, okay? Put 30 cc's of air in, okay? And that's don't go in. So this is either don't go into the esophagus or the trachea. If it goes into the esophagus, no problem, because this balloon is going to inflate and block off the esophagus, and then this has ventilation ports here, because this part is going to sit over the airway. So it's a very good airway. A lot of EMS agencies are actually using this front line for instead of intubation. And then you can sort of see how that looks there. So it's going to go in one place or the other. So if this goes into the trachea here, then this is going to block off the trachea, and it's still going to protect. Okay, so this is the one that's the most common. They're expensive. I've got one because it's expired. But it's definitely good for a rescue type of airway in case I can't get them, or a BLS. Let's say it's outside your scope of practice, and so you can just sort of shove this down in there. I've used these before on people who couldn't get intubated for some reason or the other, and they work fine. They oxygenate fine. You get a good sat. You get good waveforms with them. So not a huge problem. Like I said, there's different sizes for different people. Ultimately, we want the intubation, okay, to work. So let's do the tube. Okay. So I'm going to pre-oxygenate the patient, have my suction ready, have my tube, go ahead and have my 10 cc syringe attached to it. I'm going to go in for the look. Now, one thing that you don't do technique-wise, on this, when you intubate, the handle goes towards the sky like this, like a 45. It's not one of these things where you do that. You hear that clicking sound? That's teeth breaking. So you don't pry back. It's not a deal where you pry back. It's where you push forward. You take this and you push the jaw up forward, like so. This is what requires the forearm strength, is when you go. So I'm going to go in. I'm going to stabilize. Might need someone to hold this down for me a second. Me? Oh, you're in the camera. So I'm going to visualize. I visualize the epiglottis. I pass the tube. I watch it go through the vocal cords. I air up the cuff. Remove the stylet. Then I want to start my confirming process. I'm having someone hold the stylet. So I'm going to put my stat cap on. All these hubs are sort of universal. I have good color change, okay? So you have to confirm the tube like in 3 different ways. So one way is the color change, okay? The second way is that I saw that it passed through the vocal cords, okay? So I'm going to document that. I'm going to document the color change. I'm going to document that it passed through the cords. The other, when this tube goes in, there's still air. There's still residual air in the lungs. So this tube is going to fog. So I'm going to have condensation in the tube, right? And then the other thing, as you breathe for the patient, okay, I'm going to listen with my stethoscope and make sure that I have bilateral equal breath sounds. And then I'm going to go over the epigastric area right here, and I'm going to listen there to make sure that there's no sounds. There's no epigastric sounds. If there's sounds there, where am I at? I'm in the stomach. Yeah. So I would remove the tube. Actually, I would leave the tube and re-intubate around it, because now there's only one place for the tube to go, right? Okay, but I would make sure there's no epigastric sounds. I have bilateral breath sounds. And then the other thing I'm going to do is that I'm going to hook up Entitled CO2, look at my waveform, make sure I have a good waveform, and then breathe for this patient, 10 times per minute. Squeeze and release, right? Do that. So the intubation itself, most of the time, is not very difficult, all right? It's just a matter of knowing the anatomy, knowing where your tubes don't go, and doing the procedure. And this is something we'll practice a little bit. Mainly, I want you guys to practice using the bag valve mask with this. Then you have some sort of device to secure it. So I would here, and I would secure it around the neck like so. And then I would mark where that endotracheal tube is. It's marked off in centimeters. So I would mark that, and that way if this tube moves, then I know it. Like if it's marked at 22 centimeters, then if it all of a sudden now it's 24, it's moved, right? So I need to replace the tube. And then it doesn't take much for the tube to become dislodged. So I would go ahead and secure this patient's head so the head doesn't move right to left or up and down. Okay. And that's the intubation. Okay. Now, extubation, pull it out, right? Let's say it's time for the patient. Patient's recovered. We want to pull the tube out. So we don't extubate the patient. So I'm going to take the air out of the tube here. This patient is conscious, so I'm going to tell him to cough, have my suction ready, like, and then as they cough, pull the tube out. Questions? Concerns? Okay. It's really important to get the right tube in the patient. When I was going through my flight medic classes, my critical care classes, when we were learning a lot about this, the teacher was up there and he was telling us about all this stuff, and we had a clip on our nose and we had to breathe through a straw the entire lecture that he was. I mean, it was a while. And so we were all breathing through a straw and our nose was clipped so we couldn't breathe through our nose. And he did that so we would learn here to make sure we're putting the right size tube in. You breathe through a straw for a while and it's painful, so like this entire time we would be breathing through a straw with a little, what do they call those, hose pins on our noses, a little clip there. All right, any questions on the intubation process? Everybody good? Okay, let me stop recording right quick.